Two, one. Please start.
Okay. Good evening, everyone. A very warm welcome to today's Bayer's EyeSight Virtual Scientific Meet. So, thank you all for taking the time to join us this evening, and we truly appreciate your presence. And in the interest of time, we will begin today's meeting. So, today's scientific session is themed at evaluating the need for change, evidence, and the insights on anti-VEGF therapies. So, over the next hour, we will hear expert perspectives on evolving anti-VEGF landscapes, practical considerations in the diagnosis, and also the management of PCV. So with this, we also have these real-world discussions on, and we hope these meetings will provide an opportunity for engaging scientific engagements and sharing of clinical experience as well. So now it is my privilege to introduce our chair of this evening, Dr. Mahesh sir. So Dr. Mahesh sir is a senior consultant and head of Department of Vitreoretina at Girdhara Institute, Kochi. So, with over decades of experience in the field of retina, he has made significant contribution to the patient care, retinal education, and also the scientific discussions. And is also widely respected for his clinical expertise and academic leadership. So, we are truly grateful to have you, sir. And we thank you for accepting our invitation to chair today's meeting. So, with that, I would like to invite Dr. Maheji, sir, to take forward the session.
Thank you, Kufail. Thank you, Bayer, for the webinar. I hope it will be useful for some of us at least. We have two speakers. One is Dr. Manjula, Retina Institute of Karnataka, Bangalore, and the other one is Divyansh Misra, Shankara Eye Hospital, Bangalore. They'll be speaking on evaluating the need for change, evidence, and insights on anti-VEGF therapies by Dr. Manjula, and a case discussion on PCV by Dr. Divans. Then after that, we have a question. We have Dr. Thomas Cherian is the moderator. In spite of having some going through some difficult times, he is here. Thank you, Thomas, for joining. We hope you will be actively participating. Then we have panel of esteemed panel, Dr. Ramesh Venkatesh from Narayan Nethralaya, Bangalore, Dr. Sumant Kumar, Eye Foundation, Bangalore, Dr. Pratibha Hande, Narayan Nethralaya, Bangalore, and Veerabhadra Rao, Bangalore Nethralaya, Bangalore. So these people with their expertise will contribute to the discussion. We will start first with Dr. Manjula, who will be speaking on evaluating the need for change, evidence and insights on anti-VEGF therapies. Over to you, Dr. Manjula. Thank you.
Thank you, sir. Thanks for the kind introduction. I'll share my slides now. Are my slides visible?
Yes, please.
Yeah. Thank you. So I'll be talking about evaluating the need for change and the evidence and insights on anti-VEGF therapies. The slides, I would be very thankful to Bayer providing the slides for academic expertise. We all know that neovascular AMD is a leading cause of vision loss in both developed and in developing countries. Before 2006, before the introduction of anti-VEGFs, we were looking at reducing the vision loss. But however, with the introduction of anti-VEGFs, we are more looking at gaining some letters and maintaining the stability. Currently, we have in our armamentarium, we have bevacizumab, ranibizumab, aflibercept, brolucizumab, and faricimab. Now, even though we have so many drugs, then why do we talk about all these and how do we manage? This is because the treatment, the timely treatment can help by drying the macula, by inhibiting the blood vessels that leak blood and fluid, and improving or maintaining the visual acuity over long periods. We all know this. But however, in real world settings, there is a significant gap and the challenges posed by barriers to achieve these goals. So what are the challenges? One is there is a difference in the individual anti-VEGF agents and the response of patients to each individual agent. And the availability of these drugs with different molecular configuration, we don't know like how to go about, whether we start with a biosimilar and then go to a higher end molecule, or we start with a higher end molecule itself. The response to anti-VEGF therapy has been found to be dependent on a variety of factors like age, the lesion characteristics, the duration, which is very important, and the baseline visual acuity. Till now, there is no consensus as to how to classify the optimal response or a suboptimal response or a poor response with these therapies. For example, let us look at the primary response. Whenever we are looking at a response, we look at primary response, that is after the loading dose. After, for example, either 3 or 4 or 5, depending on the physician discretion. If you look at the first OCT topmost, you see the patient comes with a distortion, metamorphopsia, and there's a drop in vision. On OCT, there is IRF, a SHREM, suggestive of active MNV. After the first injection, there is a reduction in the IRF, but still SHREM is there. After the second injection, there is a complete resolution of the SHREM as well as the SRF. So this is the primary response. This depends on whether 2 injections, 3 injections, how we practice. The secondary response is after the 4th visit, because in the first 3 visits, we treat them aggressively. We treat them monthly. We know there is improvement in the functional as well as anatomical outcomes. But after the 4th visit, treatment depends on each individual physician, how they take it, whether they do PRN or they do a treat and extend. So the outcome, what you see in primary response, does not correlate with the secondary response unless we treat aggressively. And how do we assess the response? As I've highlighted you, one is the functional outcome, that is the visual function, which is assessed at baseline and each follow-up visit. And the anatomical outcome, this is the macular morphology, which is assessed by OCT. If you look at this column, they have the response. How do you classify the response? Whether it is good, partial, poor, or no response. If you look at the functional, which I give very much importance to, improvement in more than 5 letters from the baseline, this cannot be taken when there is a good visual acuity. And the morphology is, there is no SRF, no IRF, or intraretinal cyst, and the reduction is more than 75%, as I've highlighted in an example. It is called a good response. Partial response, there is an improvement but doesn't qualify as a good response. There is a mild increase in the letters. The reduction of the central retina thickness is between somewhere 25 to 75%, with mild persistence of the SRF, IRF, or a new appearance of IRF or SRF. This is taken as a partial response. There is an improvement in the visual acuity to some extent, but the morphological changes suggest there is a persistence of activity. Poor response is considered when the functional outcome, there is no change in the vision, the best corrected vision, and the morphological changes are minimum, that is between 0 to 25%, appearance of a new IRF or SRF. No response when you observe there is a blurring of vision or loss of letters, and there is no change or there is an increase, which we all have come across in our practice. So there is a good, partial, poor, and no response. Now, why we have to understand this is how to manage these patients. See, if the patient response is good, then all is well. But if the response is poor or there is no response, we need to change or we need to switch. So switching, whether it is a hope or a hype. Now, they have compared the real world studies of faricimab after they shifted from aflibercept to faricimab. So here, if you see in these studies, in treatment naive eyes, there was the gain of letters was significant. However, when they switched from aflibercept to faricimab, the gain was less. Again, in Moorfields and Retina also, they showed that, in fact, in switching from other anti-VEGF, the gain was better, but switching from aflibercept, it was not very significant. Why this happens? Why the switch doesn't give rise to functional improvement? Here, because there are two things to look at. Most of them discontinued in these study. Most of them discontinued faricimab treatment, mainly because one is the insufficient efficacy, or otherwise they switched back to aflibercept. This was because they noted that there was no change in the visual acuity. There is definite some anatomical improvement, but that didn't correlate with the visual acuity, and the interval between the injections, somehow they needed more injections. This could be the reason why they were shifted back to the original drug. So in this, after 3 faricimab injections, even then after the 3 loading doses, even then the extension could not be beyond 8 weeks. So when they compared aflibercept with faricimab head to head after 3 injections, the number of letter gains was more significant in the aflibercept group, which was around +3, compared to faricimab group, which is around 0.5 at month 1, which was sustained up till 3 months. Now, even in the DME, the previously switched from aflibercept to faricimab, the injections, the visual gains, everything was not significant except for the anatomical improvements. The injection sequence also, if you compare this cycle, more than around 47.6% required every 8 weeks or less than every 8 weeks faricimab injections. Despite multiple injections, majority of they were not able to extend beyond with no functional improvement. This was published in JAMA Ophthalmology when they were evaluating the effect of switching, especially in neovascular AMD and DME. They noted that they shifted from one anti-VEGF to other anti-VEGF when there was no anatomical outcome. However, when after switching also, the anatomical outcomes were slightly better, but the functional gains were minimum. So they were like, the meaning they thought that a control group which was maintained on the original drug should be done in patients who are switching from one drug to another drug after a few months or few injections of the original drug. Then we'll have a real picture whether the only looking at the anatomical gains or we are also looking at functional gains. If there is no functional improvement, there is no harm in maintaining the original drug. Now that is the switch, is whether we have an advantage of switching from one molecule to another molecule, that depends. In our practice also, we have seen some people do very well and some people don't. That may be because of the disease per se, not because of the agent. Now, other additional pathways beyond VEGF that we have to look at. See, there are many pathways which we are looked at. One is the Ang2 inhibition, which can be done with either nescavimab or faricimab, or a higher molar dose with a small antibody fragment, which can be done with brolucizumab, and a surgical implantation, that is ranibizumab port delivery system. Now let us look at individual drug pathways. When they combined aflibercept with nescavimab, they did not find any significant change either in the morphological outcome or the functional outcome. So aflibercept monotherapy was almost similar to a combination therapy. There was no additional functional benefit. Coming to the anti-Ang2 arm along with VEGF, which can be provided by faricimab. Faricimab actually blocks both Ang2 and VEGF-A. So we know that the landmark trials, LITANIA and the Yosemite and Rhine, they showed non-inferiority of faricimab compared to aflibercept. I was surprised when I looked at this slide. They said that the plasma Ang2 concentration, they compared ranibizumab with faricimab. They injected, in one group, they injected ranibizumab. In other group, they injected faricimab in different strengths. And they saw that the Ang2 inhibition was ranibizumab was almost similar to faricimab. And there was no difference in the primary endpoint superiority of faricimab when compared to ranibizumab. So that's why FDA has told the contribution of Ang2 inhibition to the treatment effect and clinical response for both AMD and DME has yet to be established. We don't know. We just know the pharmacokinetics. We don't know which is working. Is the VEGF suppression or the Ang2 suppression together? But determining when you see the long-term effect of both aflibercept and faricimab, they're almost similar in our practice also. So I think it's the VEGF suppression which acts better than Ang2. And there is also a proof that when you suppress VEGF strongly, then the Ang2 levels also comes down. This is done here. Aflibercept suppression of Ang2 helps in retinal vascular permeability also. So is it like a VEGF pathway which leads to Ang2 suppression, or Ang2 suppression acts separately in inhibiting all these is very debatable. So now if you look at, we know that aflibercept not only acts on VEGF, it also acts on PIGF. So whether that will add on to the effect that we should see. VEGF, by blocking VEGF, we can reduce the inflammation, we can reduce the neovascularization, which can in turn improve the retinal vascular leakage as well as the edema. Now, when we talk about VEGF, When VEGF suppression happens with all other anti-VEGF, additional PIGF still will be working. That can also lead to inflammation, that can also lead to neovascularization and the related effects. So by blocking both, we are completely suppressing the pathways which lead to these, and we can break the cycle better. So to summarize, with aflibercept, we have already targeting the key pathways, that is VEGF and ultimately PIGF also, in completely blocking the inflammation as well as neovascularization. So I was discussing with Dr. Mahesh Shanmugam sir, he was telling me that even 2 milligram, if you give the dose more, it can work better. But I've not compared the effect compared to whatever I give 0.05, and I'm giving almost like 0.08 now of Eylea. So increasing the molar dose of an anti-VEGF may also have the offer to more extended VEGF suppression that we need to look into. I think Dr. Divyansh can put a more insight into that. So now they are releasing aflibercept 8 mg, which is the higher molar dose. And there are studies like Pulsar and Photon, which suggest that it has a potential for greater and longer lasting control of the underlying disease compared to aflibercept 2 mg through a sustained disease control. So to highlight, aflibercept is targets the key VEGF pathway, therefore blocking both VEGF and PIGF. And at this point, it is very difficult to say whether Ang2 has a role in the pathology of this inflammation and the neovascularization. However, these two potent drugs act in a different way but produce a similar result. Aflibercept, by reducing the cost, the upfront cost has come down now. At least in my practice now, I give more of treatment-naive patients I'm selecting for aflibercept, and this has given me a good result. Initially, I used to select aflibercept and the higher drugs only for those people where either the response is poor or I'm not able to extend beyond 8 to 10 weeks. There I used to select the other drugs, but now with the cost reduction, with the easy availability, and with 8 mg available, still has to be available in the market, this has opened up a new pathway, like where we can also do a study by introducing Eylea as the first line drug. So I would like to thank Bayer for giving me an opportunity to talk in this forum with all nice people, all stalwarts in retina. And I would like to thank the sponsors also. Thank you.
Do we take up the questions now itself, or do we go to the next talk and take it up together?
No problem. We'll finish the talks and then take.
Yes, sir.
Yeah.
Sure. So thank you, Bayer, and thank you, Mahesh sir, for the opportunity for the presentation. And just to answer Manjula Madam's question as to what happens with the outcome of high molar concentration. So the outcome is not very significantly different from the same 2 milligram is what I would suggest, and that's what our in-house small set of cases which we are giving is what we have seen. In some cases, we have seen increase in interval in between the injection, but not in all, I would suggest. So it's not a very clear-cut yes and no for that. So let's start with the case presentations. So this is a disclaimer. So the first case is a combination therapy. As in the current era, just very recently, just before starting this webinar, we were discussing whether do we have the possibility of PDT be available right now? That the answer would be yes in India, and it would be available at most of our centers very soon. So this is a case which is young 40-year-old male with right eye having 6/18 kind of a vision, and the other eye is nearly 6/6, a very good vision in that eye. And the right eye, he had undergone some surgery for spontaneous vitreous hemorrhage where the oil was filled, pressures were a little on the higher side. And when I could see inside, this was the presentation. So this, as we can see, is showing like a subretinal or a sub-RPE kind of an hemorrhage, which is there in the right eye. Okay, that eye has a little lesser vision, but in the left eye, which actually is a 6/6 vision. So to start with, it is a young male which has this kind of presentation, and as we know, pachychoroid can present with this kind of neovascularizations. Octa is showing like a big network in the right eye. The left eye, there is not a very clear-cut network. In the FFA ICG, this is the older flash-based ICG, where in the right eye, it's very clear-cut that there are some polyps. In the left eye, there is a PED. Inferotemporal, there is an area where there is old focal laser done, and this was a little hyperfluorescent area, which we could see in the papillomacular bundle. And considering that we did not see any polyp in the left eye, we started with the management. As you can see, there is a big list of all the injections which we have given in this case. And this list continues even beyond 6, as we could read through 2025. So this was the left eye where we had first given the injection of aflibercept, and then the vision more so remained the same. And then considering the patient's unwillingness, we tried Dapilernon for 1 or 2 months. It didn't work out. Actually, the PED or the sub-RPE hemorrhage had actually increased. And there was a new PED temporal or inferotemporal to that area. And the OCT showed very clear-cut signs of like a thumb-like PED and elevation, and with the stepladder PED just temporal to that, which was very evident that it would be nothing else but PCV. And one eye having the PCV, other eye, very high chance it would also be having it. So as we can see, we continued with injection of aflibercept. Yes, there were some responses which was not adequate or improper, but as you can see, after around 4 or 5 injections in the left eye, the submacular lesion has regressed, but there is some extramacular lesion which has come up. And at this point of time, we had repeated the ICG. Again, it was a flash-based ICG. We can see right eye, large area of BVN. And in the left eye, where we were not seeing a polyp, now we are able to see a polyp just at the edge of the PED. This is after 4 injections of aflibercept. As we were discussing, what is a poor response? We do not know, but we know that these cases would require multiple injections. And this is after post PDT, and we had given ranibizumab. As we can see, this is for the full half fluence PDT and full dose. This is the time when we had the HLO based ICG, where we can see that the right eye is nearly suppressed, but in the left eye there is still those polyps at the edge of the PED, and in the eye octa also it is suggested. So this is after repeating the full fluence PDT. And to keep this suppression, as we can see now, the PED has gone away completely, both the eyes, to continue the suppression in the vision. We can see that aflibercept has worked very well, and as we can see, this is after 10th aflibercept that things are very well maintained. And if you can see on the right upper corner that the vision in the right eye is 6-12, in the left eye it is still maintaining 6-6. This is at the time of recurrence, we thought, okay, let's increase the dose, because at this point of time we did not have the option of PDT. So we switched to the brolucizumab molecule. As we can see, the response was not very adequate in this case. So the whole crux is these kind of cases require a lot of injections, and yes, in certain times if there is a rescue treatment like PDT, that works very well. But yes, the treatment saga still continues and the injections need to be given. Let's move on to the second case. This is a case of a 69-year-old female, which initially in her younger ages were treated with focal laser for some CSCR. As in this case, the patient had presented with nearly 6.669 vision in the left eye, some perilesional hard exudates, which suggested a very small area of a thumb-like PED and kind of an SRF, which is very close to the macula. Octa is suggesting that there is an MNV. ICG, this is suggesting that there are big, large polyps with BVN, which is very close to the macula. So in this case, we had considered aflibercept and then PDT. And this patient, for some reason, even until 3 years, there were no recurrence. So probably we can have this discussion later on. There are certain sect of patients which very poor recurrences, means 2 years, 3 years, they are completely quiet even after some treatment in the initial phase. So let's move on to the third and the last case, which is like a monotherapy of aflibercept. So this was a case of a 68-year-old male which had 612, 624. And this was a case with bilateral presentation, as you can see in the right eye and the left eye, SHREM, PED, thumb-like PED, and stepladder kind of a PED, intraretinal fluid. For some reason, left eye fixation was not so good. We couldn't do the octa, but considering the presentation, we started with aflibercept at the go itself. We can see that the neovascularization is significantly regressing and more dead-tree kind of appearance. Vision, as we can see, is 6.9 hovering in the right eye and 6.12 in the left eye. So this is after the 4th injection, near complete resolution, 5th injection, and this was a time when the COVID had stuck. And then he came up, and then there was a significant recurrence As we can see, the recurrence was both in both the eyes. The right eye showed SRF, in the left eye IRF, SRF as what it was, as good as at the time of presentation. So we started with the doses of anti-VEGF, aflibercept, and this was initially monthly 3 doses of loading injection, and then we can see the near complete foveal dryness with some PED and sub PED kind of slit-like areas, which may suggest that there is some activity still going on to the sub PED area. So we kept continuing aflibercept and kept extending the interval in between. So as we can see now, we started with the treat and extend, and in this case, because the patient had stuck very well, and then we were able to manage and suggest the treat and extend protocol. In this, we were able to even extend till 3.5 or 4 months. Certain times even I had tried beyond 4 months, but in view of recurrence and the vision which was getting affected, we brought it down to 3.5 to 4 months. So as we can see, we were able to manage this patient more so around 3.5 to 4 months, which is a fairly good time in interval in between the injections. And this is a near summary of this patient that we started with pretty significant subretinal fluid, intraretinal fluid, and in between had very good response. And as we tried to keep increasing the treat and extend protocol, we did go till 3.5 or 4 months, but we couldn't extend beyond that. So points to ponder, or the points of discussion, would be combined therapy, whether that works better, or monotherapy, in which cases should be preferred. So I think this is from my end, and thank you for the attention, and we are open for the discussion.
Thank you, Dr. Divyansh. Thomas?
Yeah. The first presentation,
Yeah,
Dr.
we have
Mansoor.
all panelists also, Dr. Ramesh and everyone is there.
The first presentation of Dr. Manjula, you were taking a group of patients where you switched faricimab and then not show good response, while another group persisted with aflibercept. So do you have any markers for this? Which group would improve retrospectively? Prospectively, you don't have any.
Yes.
Retrospectively now, do you have any markers? Which group does respond to faricimab and which group doesn't respond to faricimab?
Yes, sir. Whatever I have seen in my limited practice, baseline visual acuity is one, and the presence of IRF. If the presence of IRF, even if you change the injection because of the suboptimal response, either functionally or morphologically, by shifting, we are not gaining much. But when there is fluid, when there is SRF, and if we change the injection because of the suboptimal response, I have seen a good response both functionally and morphologically. The IRF and the SHREM, the more the SHREM is, the limited vision, whatever I have seen in my practice.
That is this IRF persistent or IRF initially?
At baseline also, and even
And
after
persistent
treatment.
after 4 or 5 injections.
Yes, sir. That is the either due to delayed presentation or worse visual acuity at presentation.
Okay. So what would be your PCV management evolving over the next few years? Dr. Divyansh and the panelists can also put in their response. What would be your PCV management henceforth? Because we have an option of Eylea, you have an option of faricimab, and you have a PDT also now back in reckoning.
So if I take the question and answer it first, so my choice of a combined therapy would be in cases where the vision is little lesser than 6.6, 6.9, or probably around 6.12. Because we know that PDT can cause some kind of minor RP atrophy, and if the lesion is exactly in the subfoveal area. So anti-VEGF choice if the vision is good, and if the lesion is at the macula. But if it's having a lot of recurrences, you have treated enough well, and recurrences are pretty significant. So in those cases, we can use like a rescue therapy PDT in those cases. So this would be my take on that.
I think going ahead, giving more of anti-VEGF first, reduce it extrafoveal lesions, maybe we have to treat with PDT. Because earlier we had a lot of experience with the PDT. Always, whenever we used to give a subthreshold, also we used to have some loss of vision. So when anti-VEGF started coming, I think most of the patients are improving and doing well. I think we need in certain cases of PDT, but I think we should give anti-VEGF first, reduce this neuron when the aflibercept or faricimab or brolucizumab. I think these three are the primary first treatments for these patients. And then once it is significantly reduced, maybe not responding cases, I think we should consider PDT.
There is one problem. Actually, many of us are not doing ICG. So where to laser, actually this is the absolute indication for ICG. If you want to laser properly, you need ICG. Many places ICG is not routinely done. That is another drawback. Probably PDT will increase the number of ICGs. And another thing is definitely extrafoveal ordinary thermal laser is adequate.
Also works.
Absolutely, it is fantastic. And all this PDT and extrafoveal thermal laser will work in almost 100% cases. The only thing is PC is a recurring disease, and after some time the BVN will grow from some other area. I have been analyzing some of my cases done 5 years, 6 years gap. After that, even after PDT, it will come back in some other area with a bleed or fluid. So it is a very difficult disease. But ICG,
also,
yeah.
Yes, my sir. Also, earlier we used to do PDT even with, FFA in fluoresceint angiogram also.
Yes.
And
but
even if the ICG is not available, I think
PDT is fine because we are treating a large area, spot size. It is, but thermal laser, you need to treat that polyp or some small bunch of polyp. You need ICG.
But thermal laser is done only for extrafoveal.
Only for extrafoveal, mainly peripapillary and all those.
But
not
these extrafoveal lesions, most of them, they have good visual acuity on presentation. Do you really need to treat them, or do you need to just observe and treat only when it's absolutely essential?
Ramesh can take that.
Yes, sir. So first I'll answer whether what we look at the clinical studies. The clinical studies very clearly says PLANET study. If you look at the 2016-2018 PLANET study, it clearly says that anti-VEGF monotherapy is quite superior or quite better compared to the combination, and use PDT only sparingly when you're expecting recurrences to happen or you're identifying new lesions which are developing elsewhere. And those are the cases where you want to use. So anti-VEGF monotherapy itself is good. Now, when you look at the choice of the anti-VEGF monotherapy, you have a lot of evidence. If you look at the PLANET study itself, it says 39% regression. But when you look at the real-world evidence with EYLEA and multiple studies which have come out of real-world evidences, you have regression rates which are achieving up to 77%. That's a great number, actually. Compare it with faricimab. Faricimab has got 61% complete regression with faricimab. Okay, so polyp regression rates are 61%. And when you look at brolucizumab, there are a few studies, very few studies, which have spoken about regression rates reaching up till 93% with brolucizumab. So the drugs are good, but if you look at safety and you look at the regression profile itself, you will realize that probably EYLEA is the best and the safe drug to give for regressing the polyps in PCVs. Regarding PDT, I think what you said was absolutely right. I think you cannot make a diagnosis of PCV itself without not doing an ICG. If you look at Divyansh's last case, if I'm not wrong, I did not find the ICG, and secondly, I did not find the OCT features which were actually matching up with findings of PCV. You did not have the tall PDs, you did not have the hyperreflective ring underneath the PD. Maybe I would have missed, or the scans would have gone up and down, but I could not. So ICG is very, very important. PDT is useful for subfoveal PCVs, subfoveal polyps, extrafoveal polyps, like Dr. Thomas and you said. I think thermal laser is the best option also, or is a good alternate option. So I think anti-VEGF monotherapy still holds good amount of evidence today to treat these patients with PCBs.
Sir, I would like to answer the question of yours, whether juxtapapillary or extrafoveal polyps, whether it should be treated or not. Dr. Giridhar et al. Have highlighted some evidences of an active polypoidal lesion. If the polypoidal lesion has that hyperreflectivity inside its lumen, or if there is an SRF, very minimal SRF, even then there is a suggestion that you please treat it, even if the patient is asymptomatic. Because I've seen many of them come with a bleed if I don't treat. If I see asymptomatic means no exudation on OCT you can observe, but if there is a minimal exudation also, it is better to treat it with thermal laser, whether they are amenable to thermal laser. Giving an anti-VEGF before thermal laser is up to the physician discretion.
Yes.
Okay.
Because it can bleed sometime and macula can get involved. So that is.
Because many a time we treat vitreous hemorrhage, we operate vitreous hemorrhage and find a peripheral PCB which has completely regressed following the bleed. So this can happen even in peripapillary.
But if the blood goes to the fovea, permanently
under the fovea, then you are in. Yeah.
When the polyp bleeds, it gets thrombosed usually. So after bleeding, even if you do an angio, you will not see any leaking polyp. So it is many times we displace the blood with pneumatic displacement at TPA, then do the angio, nothing will be there that day. So this happens. The problem of switching that was discussed nicely. There is a the when we switch decides the outcome. Actually, many times a lot of people don't know the definition of switching. I mean, when to switch also, like what is resistance, and so after 2 injections there is no response, they will switch to another one, and so this sort of Dr. Manjula, can you just for general people, can you just highlight these points? When to switch?
Yes.
After how many injections? Yeah.
Yes, sir. So the practice of switching is slightly different in the US and in India, because there they give us the loading dose, and ultimately at 16 weeks they analyze both the OCT features and the vision, and then they switch. But here we have an opportunity of seeing the patient early at probably 1 month or 2 months. My threshold will be 2 months, sir. If I don't see a response either morphologically or functionally at 2 months, I would like to switch, especially in neovascular AMD, because here the vision gain and maintaining the vision is very important. I would like to try 2 injections before switching, sir.
Absolutely. And this is, anyway, today's discussion is mainly PCV, so I'm not going to DME. DME is entirely another...
different ballgame.
Yeah, different ballgame.
I want to differ with Dr. Manjula, because I think all the suggestions are for the loading dose, and currently with the higher molar concentration, the better anti-VEGF, the loading dose is not monthly, so it is 2 months, or sometimes we are giving even more than that. So I would think about rather than number of months, but rather number of injections. So at least 2 or 3 would be my cutoff, but because in studies they have even gone high as 5 or 6 also. So that's a very kind of criminal for a patient, that if they are not responding, why to wait till 5th? But I think there are certain studies which are suggesting that far to go for the loading.
I agree with you.
My threshold is also for 2 injections.
Again, the non-responders, which is not responding, which Dr. Divyan said, is it that group of true non-responders or the poor responders? Because Manjula ma'am gave in 4 groups. You have good responders, moderate responders, poor responders, and non-responders.
So the answer is it starts beyond the loading dose. So that's why I was suggesting that leave the loading dose, and then after that, yeah, that's the call when we have to take, whether after the 2 or 3 injections, because I feel 3 is most ideal. Beyond that only we should think about whether they are responders or non-responders. So that's what the studies have suggested. But being in India, we probably even switch for the first injection. Okay.
Yes.
Means.
Actually,
theoretical versus practical kind of in real world.
The response is based on, I think, the SRF and the IRF fluid activity. That is 75 to 100%, 75 to 50, 50 to 75, less than 50. That is how it is. But PCV is one disease where activity is also based on when you have a PED. pigment epithelial detachment. You can have a disease of an active PCV where you just have the multilobulated or a double hump PED without any SRF. Now, the responders or your classification of response does not include the PED height change. It talks only about the fluid within the intraretinal space or the subretinal space. So the way we need to look out for PCV is would be different. Even a reduction in an exudate, if the hard exudates are present in a patient with PCV, and that is reducing following your injections, it is response. If the SHREM is reducing after your injections, it is response. It is response. It cannot be always be documented where in terms of quantity, whether it's a 75 to 100%, which bracket it falls into. We don't have to always classify it for PCV cases, because PCV, one disease where the lesions, even a sub-RP bleed, is a sign of activity. A sub-RP fluid or a pigment epithelial detachment is a sign of activity. So SRF and IRF cannot be the absolute ways of looking at responses.
Yeah, I have one patient.
I completely agree with Dr. Ramesh, because 2 injection or 3 injection is a little bit difficult, and especially with the classification which Dr. Manjula spoke about. It only identifies the IRC and SRF and the fluid compartment. But I think in cases of in cases of switching, which we do, especially in PCV patients, several of my patients might show a dryness, but we want to go beyond the dryness, and several times you want to see the amount of polyp regression. So I have switched several times because of the very fact that the PED heights have been constantly that way, and my repeat ICGs do not show a polyp regression. So polyp regression is something which probably we will chase nowadays, just to prevent the recurrences. As Dr. Mahesh was telling, they might come back after several months with a bleed. So in PCV, we can't treat like other diseases, because if you say that the patient is going to be on a long-term 16-week or 12 weeks of injection-free period, they can come back with a bleed, which might be so difficult to salvage after some time. So polyp regression is something which we commonly have to chase in PCV especially. And I think the switching also we have to do in such cases when we don't see a good polyp regression.
Which drug you prefer to switch to from Eylea? Suppose you are switching from aflibercept, which other drug you will like? You will go for brolucizumab, or what is any preference on experience?
I have seen a better response sometimes. I've seen in most of my PCV cases, Eylea does very well actually. And there are certain group of patients who do not respond to Eylea. In them, definitely I have seen improvements with faricimab in few cases. And my go-to drug is usually brolucizumab, because it usually works fantastically well in PCV cases. In resistant PCV cases.
If there is hemorrhage, this is a higher molar concentration, smaller molecule, it penetrates deeper. So it is the strongest probably anti-VEGF, but with its own problems.
Can I make a small?
Yeah, I have one case, sir. I just want to discuss. Yeah. Actually, I recently treated one patient with a large PED with a minimal subretinal fluid subfoveally. 2 injections of Eylea I gave monthly. Then there is initially in first injection I could see some reduction in the SRF, no reduction in PED. Then after 2 injections, I felt it is subfoveal, very large PED, something can happen. So I switched to brolucizumab. I gave brolucizumab. After 15 days, I saw day for yesterday that patient, there is no reduction at all. So what to do now? And I want to wait another 15 days and see how the brolucizumab responds. Yes, Ramesh.
Here I'd like to bring in another point. Many of our patients, the primary treatment of PCV for a long time has been Eylea. We have been treating mainly with Eylea. And one of the reasons was you pay for 2 and get 5 injections. That was the Eylea for You program. Now that is not there. Would our patients still be continuing on Eylea, or would you like to switch over at the earliest available opportunity?
In other words, whether the economics affect your choice differently currently?
The answer is yes, sir. Yes, always.
I just want to tell you that see, though the Eylea for You program is not there, but if you are planning for 2 injections or 2 injection loading doses or 3 injection loading doses actually doesn't make much of a difference actually, because the upfront cost which you end up paying with faricimab, so that is the only thing which has got a patient support program. So when the upfront cost is so high that most of the people would not be really willing to go for the patient support program with faricimab. In fact, with the reduction in Eylea cost itself, which is around 38,000 in our center, you would realize that if you give the two monthly interval loading dose schedule instead of the monthly, you would realize that most of your patients are actually converting and they are sticking on to Eylea itself. So I think the patient support program, because faricimab has a very high upfront cost, you tend to the patient actually thinks twice or thrice before paying 75 or 80,000 rupees at the beginning.
That is correct. Actually, I am little against this patient support program. Anybody has tasted how it works? My dad had an injection, so I gave my phone number, and that person from call center asked me, your injection is due on this and this date. You have to pay 500 rupees for processing charge. Then only you will get. Are you ready to pay by GPay now itself? Otherwise, it will get. He is talking to me like a. So this sort of thing. I think Bayer has done a very good job that it has reduced. I hope in the next 1 year they will reduce it a little more, 5 to 10,000 more. Then they will have plenty of cases. That is what I
something
wish.
more interesting. Something more interesting which I noticed with the arrival of biosimilars, when we had only Accentrix and then we had the ranibizumab biosimilars, the market of Accentrix collapsed like anything. But that has not happened with Eylea. Despite the arrival of a biosimilar, the market of Eylea is maintained, at least maintained, if not more, when the patient support program has been taken off. So what is the experience of the other surgeons here?
I don't know whether Bayer is going to allow these questions.
Very true.
No,
Very true.
actually, in my practice, the Eylea is not reduced because the cost is significantly reduced. And now, for almost around 30,000 plus, we are giving these injections, and many of them are affordable.
Dr. Veerabhadra Rao, to answer your question, please do an ICGA. Where are we? Why the PET is not responding?
That is
correct. Actually, because I don't have ICG, I didn't do the ICG. But anyway, I'll see. I want to wait another 2 weeks and again back that case based on the response for this policy.
Sure.
But there is no reduction in PED in this case.
Dr. Sumanta is there, who is in the panel.
I don't think
good evening, sir. So my limited experience with the PCV, sir, my go-to drug is Eylea. So I've not used any biosimilar still now. I've got two sides for Eylea for you. Some patients happy, but most patients are happy that the initial cost has come down. My injection is 1 to 2 months. I don't follow the strictly monthly loading dose, especially if the lesion is small or. If I get a good response in the first injection, but I follow them monthly, but injection may not be monthly. At the most 2 weeks if the patient is not affordable, but those who have insurance, I stick to monthly injections. Sir. Vabysmo, I've not used any, I've not switched from aflibercept to Vabysmo. My only thing is I got one patient who had a young patient, 40s, who presented as CSR, referred for FFA ICG, but the patient was panicking. I did FFA, but it didn't show any leak. But she had panic attack, so I had to stop ICG. I told her you may require injection, but she was not willing. So she came back after 2 weeks with a submacular hemorrhage. Luckily, with a large submacular, almost arcade to arcade. I did pneumatic and I gave 5 doses of Eylea over almost like 2 years. Initially, loading dose, then once in 3-4 months. almost like 5 years now. She has not recurred. I didn't because I didn't do ICG in the first, and later on also I have not done ICG. So only my concern is when to extend. Is it 3 months or 4 months? Especially with submacular hemorrhage, like when do you suggest ICG at end of, because now it's monotherapy. Should we do ICG, or if you have a facility, or get an ICG before we extend, or we rely on OCT itself to predict the recurrence, especially with submacular hemorrhage? Though they can close, but there is a lot of cases who have small hemorrhage with exudation.
Actually, ICG is done after displacement of blood once. Then, if there is no response to your injection, two. These are the two indications whenever it is not working. So that is what I do, because we have to switch the drug. Before that, we'll make sure what is happening beneath. So nowadays, that angiography is a little reduced because of this OCT.
Yes, sir. That's with the center where I work also.
Nice.
Earlier we used to, with PDT, we had a lot of ICG.
Yeah.
We used to do. Now without PDT, we are relying on OCT itself.
Yeah. APVRS has come out with the guidelines of non-ICG diagnosis of PCV. 95% you can diagnose. Where to give
No,
less?
sir. It's only the recurrence, like polyp regression, like what we tell with monotherapy. Is that anything like on ICG? Because we have stopped doing ICG, it seems.
Recurrence, I don't think large BVN and this will ultimately recur. 100% it will recur. When, I don't know. Any other Pratibha, Dr. Pratibha, or anybody?
Yeah, I usually do the repeat ICGs. I think Dr. Suman's question was when to, how do we actually, when to do the repeat ICG to see for the regression of the polyps. So I usually follow up the patient with OCTs, and once the PED completely flattens, and I'm going beyond 12 weeks of follow-up, in the sense TND regimen, with the regimen extended up to 12 weeks, I prefer doing an ICG at that stage. That gives me a little bit of a surety that I can follow up the patient once in 3 months with injections. And if I see an BVN on the ICG, I tend to call them, in between, lesser than 12 weeks, because I'm a bit nervous about the possibility of subretinal hemorrhage.
Yeah. And Thomas' question on biosimilars, biosimilars of aflibercept.
Yeah.
It has come, but it has not launched that. Initial, there are some teething problems. In an AMD, our first choice, even now, after 12, 14 years, is Eylea, because of the evidence that we have. That is one thing. There is no doubt. Because this is the only drug which I think none of us had any vasculitis anytime in the last 12, 14 years.
Not at all. Yeah.
Very true. Very true. No safety issues at all.
Absolutely. So that is so anybody in our family gets also, this is the safest drug. So that is it. And now that we are going to get 8 milligram Eylea by the end of the year probably. So that that will further reduce the need for injection. That is another thing that all of us, durability question. So that is another good thing that is going to come. And like Divyansh is telling, actually from long time back, we give 0.1 ml, whatever drug it is, except brolucizumab. It is not 0.1, it's less than 0.1.
Yes, sir. Actually, whenever we give, we inject a complete drug into that.
Yeah, 0.1, little less than 0.1, because when initially our fellows used to give 0.05, nothing may enter the eye. 1 month later, there is absolutely no change. So little extra. So we have been giving a little extra for the past 20 years, actually.
Do you do this for brolucizumab also?
No.
Brolucizumab
will not.
So yeah, the cases and also be careful in a biosimilar, means because then the chance and the risk of having inflammation. So
no, Axenrix and Eylea definitely, and even so that is another thing. So these are, brolucizumab is any day but most dangerous. Thomas?
Yeah. Sir, I have one question. I just want to know that if you're giving more drug, 0.1 ml, or you're giving some people
little less than 0.1.
are you not increasing the risk of complications in the sense that the safety profile itself, are you not? Because see, you are worried about brolucizumab because it has got high molar concentration of the drug. You're giving
Yeah.
more particles or more drug inside the eye. Now you're doing the same thing with aflibercept. You're going to do the same thing when aflibercept 8 mg is going to come. Aren't we worried about? And we have realized from Divyansh's message that he did not find a significant difference in the response, whether you injected 0.05 ml or whether you injected 1 ml or whether you injected 2 mg or whatever it is. So we did not find. Aren't we risking the patient with more drug inside the eye?
Like, I mean, in what way? Inflammation?
Inflammation,
Or,
yes.
Inflammation. But I don't think Eylea, that's what somebody told. Biosimilar and other things, brolucizumab, we never give more than 0.05. So this Eylea and probably ranibizumab, it is, I don't think there is any risk for inside the eye. But theoretically, I have another, I am not starting that. the absorption and VEGF trap blocking the VEGF systemically, leading to even nephrotoxicity is also high if you inject too much.
Yes.
So that is the
Side
current.
effects are higher rather than the ocular one is what the molar concentration studies have suggested, because because there are not enough receptors in the eye, so it tries to escape out, and then systemic absorption. So that's what has been suggested.
That Ramesh's point is correct. Systemically, so in sick patients and some risk factors, it is better. Not
just one question.
Yeah.
This 8 milligram aflibercept, is it equivalent to 2 cc of 0.5 milligram, 2 milligram aflibercept?
To me, I don't know.
That is simple mathematics which I am asking.
Yeah. But you have to give 0.2 ml is too much inside.
Then you have to have AC tap of 0.2.
If that is the case, then 1 ml of 2 milligram aflibercept should be absolutely safe.
So when we came to Cochin, sir, with Michael Stewart for the Cochin meeting, we asked this question actually, that by giving an 8 mg, aren't you increasing the risk by 4 times compared to the normal regular aflibercept? So he said, yes, theoretically the risk is 4 times more what you expect, but he did not encounter any findings of inflammation. In fact, he said about one case which he encountered. But I think by injecting more or giving a higher dose or a higher drug, though we are able to achieve longevity or durability, but there could be a chance that we are increasing the risk of inflammation also. So I'm not sure, because we haven't used 8 milligram aflibercept till now, so we don't know. But that is something which we will have to think, especially when you are giving a 2 milligram aflibercept and double the doses. I think we really need to be careful about it.
Yeah.
It's especially not double the dose, it is just 0.02 ml more. That's all. 0.05 is the conventional dose, and 0.07 what we give, that is helpful.
So any other questions in the chat box? Somebody?
If I could just answer Dr. Thomas's comment on aflibercept biosimilars, that yeah, we do have a problem with intraocular inflammation with the aflibercept biosimilar which we have currently. But I think the data with aflibercept itself is so robust. I think anytime you have a patient with PCV, before considering any kind of a biosimilar, aflibercept just stands out and says that, okay, you have so much of data which is there, which tells you that it is one of the safest drug, effective drug. You are able to achieve longevity. You are able to do the treat and extend regimen. So you tend to switch. You tend to keep aflibercept as the drug of choice, and your requirement for shifting to a biosimilar actually reduces. It doesn't change much, especially for a very aggressive disease like PCV, where you don't want to try and give a trial of something which you're not experienced with. You always want to go with something which you're more experienced with, more data available. And I think aflibercept, that's why still has a good number of cases which have not been shifted to the biosimilar group.
Right.
We are nearing 8:30. So
yeah. Anything? Any other questions from the attendees, or we can wind up?
I had one input about Dr. Divyansh's case, wherein he showed the case with a post-vitrectomy where he actually has used PDT and it actually did very well. So that's an important indication probably once we get PDT. These are the kind of cases where we had a submacular hemorrhage, you do a vitrectomy. And then I have a few cases, they require injections so much that I'm not able to extend. So probably PDT in such post-vitrectomized eye does better than an anti-VEGF injections. So that is probably a strong indication for PDT in PCVs. Otherwise, I always thought once PDT comes back, I'll be using it for my CSCR patients more than PCV because the anti-VEGFs are so good.
Right.
Okay. So thank you very much. Thank you, Dr. Mahesh, for chairing the session, Dr. Manjula and Dr. Divyansh for the wonderful talks, and to all the panelists, Dr. Ramesh, Dr. Pratibha Hande, Dr. Sumant,
Dr. Veerabhadra
Rao, for the active discussion. Thank you once again. Good night.
Thank you.
Thank you, sir. Good night.
Thank you.
Thank you, Dr.
Thanks to all doctors. Thank you.
Thank you, sir.
Thank Bayer for this thing, and back to you, Kufail, for winding up the session. Thank you.
Thank you, sir. Yes, sir.
Thanks to all doctors. Thank you. Thank you.
Yeah, thank you.
Thank you.
Sir, can we close this session?
Yes, sir.
Okay, sir. Thank you.